Welcome everyone to the Emergency Room podcast. Get ready to have your mind blown by this episode. We're about to unlock the secrets to saving lives with fibrinolysis in pulmonary embolism. This isn't just another medical lecture. It's your key to understanding and feeling confident about managing one of the most critical conditions we face. So take a deep breath, relax, and let's get started.
Hello and welcome to the Emergency Room podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
Today, we're focusing on the use of fibrinolytic therapy, also known as thrombolytic therapy, in patients with acute pulmonary embolism. This is a critical intervention, but it comes with significant risks, so understanding the nuances is essential. Fibrinolytic therapy for acute pulmonary embolism. Fibrinolytic therapy aims to dissolve blood clots quickly and restore blood flow. In the context of pulmonary embolism, this helps to reduce the thrombus burden and improve right ventricular function faster than anticoagulation alone. Key fibrinolytic agents. Here are some key medications and their characteristics. Remember that these are powerful drugs, so it is imperative to understand their pharmacology, indications, administration, and contraindications. Streptokinase. This is an older agent that works by activating plasminogen, which then breaks down fibrin clots. Think of it like a tiny army of molecular scissors going to work on the clot. Dosage and administration. It is typically administered as a 250,000 international units intravenous (IVR) infusion over 30 minutes, followed by 100,000 international units per hour over 12 to 24 hours. Streptokinase is less commonly used now due to its higher risk of allergic reactions and its less specific action compared to newer agents. Tenecteplase. A newer recombinant tissue plasminogen activator that is more fibrin-specific than streptokinase. This means it's more targeted, reducing the risk of systemic bleeding. Dosage and administration. This drug is weight-based. A single IV bolus over 5 to 10 seconds is given as follows. Less than 60 kilograms, 30 milligrams, 60 to 69 kilograms, 35 milligrams, 70 to 79 kilograms, 40 milligrams, and 80 to 89 kilograms, 45 milligrams, greater than or equal to 90 kilograms, 50 milligrams. Note: this is a one-and-done medication. A single bolus is typically sufficient. Alteplase, another TPA that works similarly to tenecteplase, but requires a more complex dosing regimen. Based on the information in the sources, alteplase administration varies depending on the clinical scenario. Intermediate high risk, submassive, pulmonary embolism. The recommended dose is 100 milligrams administered intravenously over 2 hours. Hemodynamically, stable high risk, massive, pulmonary embolism. The dose is 100 milligrams intravenous over 2 hours. This suggests that the administration is similar to intermediate high risk PE patients. Hemodynamically unstable high risk, massive, pulmonary embolism, or cardiac arrest. Administer 50 milligrams IV as a bolus over 2 minutes. Contraindications. When not to thrombolyze. It's crucial to balance the risks and benefits of thrombolytic therapy by carefully evaluating contraindications. These are broadly categorized into absolute and relative contraindications. Absolute contraindications. These are conditions that make thrombolysis too dangerous and therefore absolutely contraindicated. These include active internal bleeding, history of intracranial hemorrhage, ICH, known structural cerebral vascular disease, ischemic stroke within the past 3 months, suspected aortic dissection, significant head trauma within the past 3 months, relative contraindications. These are situations where you need to weigh the risks and benefits very carefully. These include recent major surgery or trauma, recent gastrointestinal or genitourinary bleeding, pregnancy, non-compressible punctures, advanced age, especially over 65 years, thrombocytopenia, when to consider, thrombolysis, making the decision. So how do you decide if a patient needs thrombolysis? It's a complex question, but here are some key considerations. High-risk PE. Systemic thrombolysis should be considered in patients with high-risk PE, which is characterized by hemodynamic instability, such as hypotension or shock. These patients have a high mortality risk and can benefit greatly from rapid clot dissolution. Think of it this way. A patient who is on the brink of collapse due to PE needs immediate action to restore blood flow. Intermediate risk pulmonary embolism. In intermediate risk PE, also called submassive PE, patients have right ventricular dysfunction, but are hemodynamically stable. Thrombolysis may be considered on a case-by-case basis.
Systemic thrombolysis in patients with PE is associated with an increased risk of major bleeding and intracranial hemorrhage, particularly in patients that are older than 65 years of age. Given the increased risk of bleeding, clinicians should carefully weigh mortality risk from PE against major bleeding risk from thrombolysis by careful assessment for absolute and relative contraindications to thrombolytic therapy. Absolute contraindications: active bleeding, prior intracranial hemorrhage, ischemic stroke within 3 months, suspected or confirmed aortic dissection, recent brain or spinal surgery, recent head or facial trauma, intracranial neoplasm, vascular malformation, aneurysm, or any other structural brain disease. Management after systemic thrombolysis. Hemodynamic improvement with systemic thrombolysis generally occurs within a few hours following the completion of the infusion. Patients should be monitored for signs of improved oxygenation, increased blood pressure, and reduced heart rate. Following the completion of the thrombolytic infusion, intravenous unfractionated heparin or a therapeutic dose of enoxaparin should be initiated or resumed if no active bleeding. Longer-acting agents such as direct oral anticoagulants and warfarin should be avoided for 24 hours following thrombolysis while monitoring for signs and symptoms of unexpected bleeding that may require immediate reversal. Signs of symptoms of major bleeding include a significant drop in hemoglobin, hemodynamic compromise, headache, nausea or vomiting, and changes in mental status. Following systemic thrombolysis, patients should undergo close monitoring.
Conclusion: a systemic thrombolytic therapy has been shown to reduce mortality and recurrence in select patients, where the mortality associated with an acute PE outweighs the increased risk of bleeding. Several guidelines recommend the use of thrombolytic therapy in patients with hemodynamic compromise and in patients with worsening clinical status following the initiation of anticoagulation. Various agents exist, with differing pharmacokinetic properties and dosing regimens that also differ based on clinical indication. Therefore, a careful consideration should be made regarding patient selection, a drug therapy selection and administration. Although a lack of consensus exists surrounding bleeding reversal of thrombolytics, most guidelines recommend the administration of cryo, precipitate and/or antifibrinolytics.
Thanks so much for joining us today on the Emergency Room podcast. Please smash that like button, it helps us reach more colleagues and keep the educational content coming. Don't forget to share this video with your fellow healthcare professionals. And if you're not already part of our community, please subscribe to the channel and hit the bell notification so you never miss out on our next cutting-edge discussion. We're dedicated to providing the most up-to-date, evidence-based information to keep you at the forefront of emergency medicine and critical care.